These now are the newborn disorders that we will discuss next. Take into consideration all of the previous immediate nursing care that we have discussed when dealing with a high-risk newborn. First is a small for gestational age newborn. It is a newborn whose birth weight is below the 10th percentile on an intrauterine growth curve for that age. A growth curve, as seen in the photo, estimates expected weight for every week of gestation. An SGA newborn may also be a preterm, born less than 37 weeks, a term, born between 37 to 42 weeks, or a postterm, born beyond 42 weeks. SGA newborns are also small for their age because either they experience intrauterine growth restriction or they failed to grow at expected rate in utero. These have several causes. One possible cause is nutrition during pregnancy. This plays a major role in fetal growth. Pregnant adolescents have higher incidence of SGAs because they need to meet their own nutritional and growth needs first. In effect, needs of the growing fetus is compromised. Second is placental anomaly. This is the most common cause of IUGR. Either the placenta uh, did not obtain sufficient nutrients from the mother's uterus, or there is insufficient uh, transporting of nutrients going to the fetus. Third are women with systemic diseases such as DM or PIH. These diseases generally cause decreased blood flow to placenta. Fourth is maternal lifestyle. Some studies show that women who smoke heavily or use narcotics tend to have SGA newborns. And fifth are intrauterine infection or chromosomal abnormality. In this case, the placental supply of nutrients is sufficient, but the fetus cannot use them because of the infection or the abnormality. For the assessment findings, prenatally, the baby's fundic height is less than expected. The ultrasound also reveals that there's a small fetal size and there's also poor biophysical profile results. In such a case, there is a need to assess for possible CS delivery, especially if there is poor placental function. For the appearance, the newborn looks wasted. There's decreased anthropometric measurements, poor skin turgor, the head is large compared to the small body, there's a widely separated suture lines of the skull, the hair, including the general body hair, is dull and lusterless, the abdomen is sunken compared to the normal protuberant, and the umbilical cord is dry and yellow. Since this newborn's age is more advanced than the weight, this neonate may also have better developed neurologic responses, so creases, and ear cartilage than expected for a baby of that weight. For the laboratory findings, hematocrit is high because of less plasma than RBC due to lack of fluid in utero. There's also polycythemia because fetal anoxia stimulates more RBC production and causes blood viscosity, which causes an extra load or workload on the heart. If there is hypoglycemia, checking for the blood sugar below 45 mg per deciliter, there may be a need for IV glucose. Large for gestational age newborns. A baby is LGA when the birth weight is above the 90th percentile on an intrauterine growth chart for that gestational age. Please refer to the same growth chart in the SGA slide. Also, these newborns appear deceptively healthy, but a gestational examination will usually reveal immature development. What are the possible etiologies? First, LGA often happens to women who are diabetic or are obese. Fetuses of these women have been subjected to overproduction of growth hormone in utero. Hence, the babies develop extreme macrosomia. Second are multiparous women. With each succeeding pregnancy, babies tend to grow larger. And other conditions also predispose to LGA babies, such as transposition of the great arteries. It's a congenital cardiovascular disorder. Beckwith syndrome. It's a rare condition characterized by fetal overgrowth, and omphalocele. It's a GI abnormality where internal organs, usually the intestines, stick outside of the belly. Assessment. Prenatally, LGAs can be suspected when a mother's uterus is unusually large for the gestational age. But to confirm, an ultrasound may reveal that the baby inside is big compared to the expected uh, size for the specific gestational age. When this happens, some tests can be done in order to detect if that baby can tolerate the stress of labor. One is through a non-stress test, which can assess placental function. Another is to check if there is fetal lung maturity, which can be done through amniocentesis. Also, LGAs can be detected during actual labor. This is when there is failure of the baby to descend down the vaginal tract. When this happens, CS may be necessary in order to prevent complications such as shoulder dystocia. For the appearance, we said that LGAs have immature development too. So there could be immature reflexes. There may be low scores on gestational exams, such as the Ballards and the APGAR. There could be extensive bruising or birth injury because the baby is big, especially when he or she passes through the vaginal canal. And there could also be prominent caput succedaneum, cephalhematoma, or molding. With these appearances, especially on immature reflexes and low scores on gestational exams, we can see that it is also seen in a preterm newborn. So, same care can be given with that of an LGA. Third is a cardiovascular dysfunction. LGAs also have a higher risk for hyperbilirubinemia. Aside from immaturity of the liver to convert indirect to direct bilirubin, LGA babies can also have this because of absorption of more blood coming from the bruises. Tachycardia may also be present because the baby is big, there is extra workload for the heart. And cyanosis may be present if there is transposition of the great vessels. This is a congenital cardiovascular disorder which we will discuss later on in the pediatric physiologic diseases. And this transposition of the great vessels is usually associated with macrosomia. Fourth is hypoglycemia. It is when the LGA baby requires large nutritional stores in order to sustain weight. If a mother has DM, we know that there is high glucose inside and it crosses the placenta. When this happens, high insulin is stimulated in utero, and this is still present 24 hours after birth, and this can cause rebound hypoglycemia. Prematurity. A premature baby is born after 20 weeks and before the end of 37 weeks gestation. But aside from that usual criteria, another criteria of prematurity is the weight. The birth weight that is less than 2,500 grams is usually indicative of prematurity, plus the first criteria. The weight can be low birth weight, very low birth weight, or extremely low birth weight. It depends on the following birth weight indicated in the slide. Box 26.7 shows the common factors associated with preterm birth, but please take note that there is no exact cause. The exact cause is rarely known. Remember also that infant mortality could be reduced dramatically if the causes of preterm birth, as mentioned in the box, could be discovered and corrected and all pregnancies brought to term. Table 26.2 shows the differences between SGAs and preterm infants. Preterm babies must be differentiated from SGA babies as they result from differing situations and will cause different problems in adjusting to extrauterine life. Remember also that not all SGAs are preterms, and likewise, not all preterms are SGAs. To be able to help identify or diagnose such newborns, always consider the basis. A full-term newborn is born at 37 to 42 weeks AOG, and that newborn must be within 2.5 to 3.5 kilograms. As an example, a 36-week AOG newborn is born preterm. Upon weighing, that newborn is 2.3 kilograms. That baby is preterm but is not an SGA. That baby is considered an AGA. On the other hand, a 2.3 kilogram newborn, the same weight with the previous example, was born, but the age of that baby is 38 weeks AOG. In such a case, that full-term baby is considered an SGA. When assessing premature newborns, one important focus is assessing the respiratory system, mainly because of the lack of surfactant. Surfactant is a phospholipid which covers an alveoli and prevents alveolar surface tension, especially during expiration. It basically prevents lung collapse or atelectasis. Surfactant is a way to check if there is already lung maturity. Lung maturity is achieved later in intrauterine life. It can be detected if the LS ratio reaches normal at 2:1. If there is less surfactant, there could be signs of respiratory distress, such as apnea, tachypnea, nasal flaring, retractions, grunting, irregular breathing, or cyanosis. For the temperature, a premature newborn's temperature is difficult to regulate. We know that even healthy newborns are prone to hypothermia, much more a premature one. Their body temperature fluctuates more easily due to lesser fat and muscles. The nutritional status is also an important consideration among the prematures. They have poor sucking, poor swallowing, poor gag, and poor cough reflex. Because of this, we always have to take into consideration proper nutrition as they feed, and at the same time, while you are feeding them, you always have to prevent aspiration. The skin. As compared to a full-term newborn with a well-moistened, beautiful skin, a premature skin is usually lacking in fat, reddened, and translucent. The cardiovascular system is also immature, so you can see possibly petechiae due to fragile capillaries, and there's also increased prothrombin time and increased bleeding time. And because of this, we always have to watch out for any risks of bleeding. Also, the neuromuscular system is immature, and such immaturities are evidenced by a poor muscle tone, weak reflexes, and a newborn's cry is also weak and feeble. One thing that is difficult in prematurity is the many complications associated with it. One is the anemia of prematurity. It's a normochronic, normocytic, hypoproliferative anemia due to increase in erythropoietin. In this anemia, there are normal red blood cells, but they are few in number. It is because the bone marrow does not increase production until 32 weeks AOG. So basically, the baby looks pale, lethargic, and anorectic. Second is kernicterus. It's the destruction of brain cells because there is invasion already of indirect bilirubin, which is again a product of fetal to RBC breakdown. This may occur as low as 12 mg per deciliter in preterms, but usually 20 mg per deciliter in full terms. Phototherapy or DVET can be done. Third is persistent patent ductus arteriosus. The ductus arteriosus, again, is a fetal circulatory structure. It is the non-closure of the ductus arteriosus because of difficulty of blood flow from pulmonary artery to aorta caused by a lack of surfactant. This leads to pulmonary artery hypertension. To help in the closure of ductus arteriosus, two drugs can be given. It's either indomethacin or ibuprofen. These are anti-inflammatory drugs which fastens or hastens the closure of ductus arteriosus in children with PDA. Fourth is periventricular or intraventricular hemorrhage. Periventricular hemorrhage is bleeding around the ventricles of the brain, while intraventricular is bleeding within the ventricles. This is due to fragile capillaries and immature cerebral vascular development. Here, hydrocephalus may occur, and prognosis must be guarded. Letter E is respiratory distress syndrome. We have discussed previously that it's a breathing disorder, usually in preterm newborns because of a lack of surfactant. It can cause atelectasis. We will further discuss this later on. Another potential complication is retinopathy of prematurity. It's a blinding disease caused by abnormal development of retina in premature newborns. This is caused by oxygen therapy in preterms experiencing RDS. We can recall that when a child has difficulty breathing, we can provide several types of oxygen therapy. This oxygen therapy, when given to preterms, can damage the retina. It is a side effect, so weaning is very necessary. Last is necrotizing enterocolitis or NEC. It is a bacterial infection and inflammation of intestines among premature newborns. It occurs in 3 to 4 days after birth And usually, the neonate is either on NPO and on ventilator. Again, we have a separate discussion of neck later on. Postmaturity is when an infant stays in utero past 42 weeks. This neonate is at special risk because the placenta appears to be effective only for 40 weeks. With such, all the functions of the placenta are compromised, namely oxygenation, nutrition, endocrine, detoxification, and elimination. Assessment findings include lesser amniotic fluid and meconium stained at birth. Vernix and lanugo completely disappeared. Dry, cracked, leather-like skin. Depleted subcutaneous fat. Hard nails extending beyond fingertips. And signs of birth injury or poor tolerance of birth process. All these findings are associated with a poorly functioning placenta and possibly fetal distress. Also, the skin and nail characteristics on the photo are common among post-mature newborns. First consideration is to monitor for any difficulty establishing respirations, especially if meconium aspiration has occurred because of fetal distress. Second, establish nutrition as hypoglycemia may occur, since fetus used its glycogen stores in the last weeks of intrauterine life. So you have to recall again our discussion on establishing nutrition and maintaining fluid electrolyte balance among high-risk neonates. Third is to prevent further complications related to hypothermia, so you have to regulate temperature as fats have been used in utero as well. Complications may lead to hypoglycemia, acidosis, or respiratory distress. Another disorder is respiratory distress syndrome. The pathologic feature of this disease is a hyaline-like or a fibrous membrane that is formed from an exudate of the infant's blood that begins to line the terminal bronchioles, the alveolar ducts, and the alveoli. This so-called membrane is very important because it prevents exchange of CO2 and O2 at the alveolar capillary membrane. Its cause is a low level or absence of the surfactant. It's a phospholipid that lines the alveoli and reduces surface tension to keep it from collapsing, especially during expiration. And again, surfactant does not form until the 34th week. Therefore, RDS most often occurs among the preterm infants, but aside from the preterms, it can also be seen among neonates of diabetic mothers, neonates born by cesarean birth, and neonates with meconium aspiration. The photo shows a mature newborn with a mature alveoli, allowing for effective exchange for O2 and CO2. The other picture shows an immature newborn with lesser surfactant, which makes it difficult for ventilation to occur, thereby possibly causing atelectasis or lung collapse. In RDS, there is insufficient surfactant and alveoli immaturity. Both can lead to atelectasis or lung collapse. First, the collapse will require forceful inspirations from the newborn. There is hypoinflation and pulmonary resistance increases. When this happens, blood shunts through an intact foramen ovale and ductus arteriosus. Lungs are purely perfused at this case, and there is poor oxygen exchange. This leads to tissue hypoxia, which then releases lactic acid, causing acidosis. On the other hand, collapse also leads to the forming of a hyaline membrane, particularly on the alveolar surface. This hyaline membrane leads to an increase in CO2, which also causes acidosis. The acidosis in this case will cause pulmonary vasoconstriction, and along with the other inflammatory cell mechanisms, it will lead to respiratory distress syndrome or lung injury. Most infants who develop RDS have difficulty initiating respirations at birth. There could be initial signs of distress such as nasal flaring and tachypnea. As it progresses, there could be retractions, cyanosis in the mucous membranes, and hypothermia. Within several hours, even if there is an attempt at better oxygen exchange, however, the child still cannot tolerate and the disease progresses, severe signs of distress may occur, such as grunting, cyanotic body, PO2 and O2 saturation falls, and adventitious breath sounds. If there is still progressive deterioration or as distress further increases, there is cease respirations, heart failure, pale gray skin, periods of apnea, bradycardia, and pneumothorax. These are signs of um, more complex complications. In the diagnostic and laboratory findings, chest x-ray would reveal radio-opaque areas, and blood gases show respiratory acidosis. These are all signs of poor gas exchange. What is the therapeutic management for RDS? Most important is surfactant replacement. There is a synthetic surfactant available in the market which can be given through the endotracheal tube at birth. Second is oxygen administration. CPAP or the PEEP machine exerts pressure on alveoli at the end of every expiration to prevent collapse. That is why children who have advanced RDS can be given either the CPAP machine or the ventilators. But always take note that complication of oxygen to premature newborns is retinopathy. That is why, again, weaning is very necessary. Third, ventilation. The normal IE ratio is 1 is to 2, and it is very difficult to deliver oxygen to a stiff, non-compliant lung at this usual ratio, similar to the lungs of a child with RDS. Forcing air at a high pressure and rapid rate can cause pneumothorax, so ventilators can either be reversed. Instead of the normal IE 1 is to 2, some ventilators develop an IE of 2 is to 1. Or there's also this high-frequency oscillatory and jet ventilators which maintain airway pressure in an intermittent oscillate or jet of air at about 400 to 600 breaths per minute. Fourth is administration of a muscle relaxant such as pancuronium IV. This drug increases pulmonary blood flow. Fifth, some are maintained on ECMO or extracorporeal membrane oxygenation. This is like an open heart surgery where blood is removed from the heart. You remove blood from a venous catheter from the right atrium. Then, the blood is delivered to a machine. This external lung machine pumps and oxygenates blood. This allows the heart and lungs to rest. Once the blood is oxygenated by the extra or the artificial machine, the newly oxygenated blood is then returned back to the heart, to the aortic arch through the carotid artery. Sixth is keeping the client warm. This prevents acidosis, therefore reduces oxygen demand. And seven, IV hydration and nutrition. These neonates are too exhausted to suck. How do we now prevent RDS? We can prevent RDS. We know that RDS is predominantly caused by prematurity and it's associated inadequacy of the lung surfactant. So one, tocolytic or terbutaline can be given to mothers to prevent premature birth. And second, if premature birth cannot be halted, we can give the mother dexamethasone 6 mg IM or IV Q12 for 4 doses according to EINC protocol. Dexamethasone is a steroid. It can quicken the formation of lecithin so surfactant matures. LS ratio again should be 2:1. Transient tachypnea of the newborn. In a normal physiology, a newborn at birth may have up to 80 breaths per minute, especially when crying because of retained lung fluid. Within 1 hour, however, this rate slows down between 30 and 60 breaths per minute. And about 10 in 1,000 live births, the RR remains high, usually between 80 to 120 breaths per minute. This is termed as transient tachypnea of the newborn. Transient tachypnea may also reflect a slight decrease in mature surfactant, but remember that its direct result is the retained lung fluid. The retained fluid limits the amount of alveolar surface that is available for oxygen exchange. TTN peaks approximately 36 hours and then begins to fade. Typically, by 72 hours after birth, it should spontaneously fade as the lung fluid is slowly absorbed and respiratory activity becomes more effective. TTN occurs often among neonates born by CS, whose mothers received extensive fluid administration during labor, and neonates who are preterm. The infant does not appear to be in a great deal of distress, aside from the tiring effort of breathing so rapidly. Plus, it is transient. But what are the typical assessment findings? There could be mild retractions, but not marked cyanosis. There could be mild hypoxia and hypercapnia. There could be difficulty feeding, and chest radiograph would reveal the fluid in the lungs. O2 may be necessary. Nurses should assist with feeding. There should be a close observation and watch carefully to be certain the increased effort is not tiring. Also, you have to watch out for signs of more serious disorders. Meconium aspiration syndrome occurs when a newborn has aspirated meconium, either in utero or with first breath at birth. Ideally, meconium is present as early as 10 weeks AOG, but it should not be expelled intrauterine life. However, release of amniotic fluid or release of meconium into amniotic fluid intrauterine life is caused by 1. Relaxation of rectal sphincter. The cause is because of any kind of fetal distress. Fetal distress caused by hypoxia further causes vagal stimulation. Vagal stimulation will then relax the rectal sphincter, causing the release of meconium. Second, release of meconium into amniotic fluid is possibly caused by pressure on buttocks. This is true with the aspiration of meconium by the fetus at first breath during birth. Babies born breech have more pressure on the buttocks during labor and delivery. Meconium aspiration syndrome causes severe respiratory distress in three ways. One is the inflammation of bronchioles because meconium is a foreign substance in the lungs. Second, the meconium, being thick in consistency, can block the small bronchioles by mechanical plugging. And third, decrease in surfactant production because of the lung trauma. All these will further cause hypoxemia, carbon dioxide retention, and intrapulmonary and extrapulmonary shunting can occur. A secondary infection of injured tissue may also lead to pneumonia. A child with meconium aspiration syndrome shows difficulty establishing respirations at birth. Listed here are those you can expect when you see a child with meconium aspiration syndrome at birth and after initiation of respirations. Prior to birth, if meconium is suspected uh, as expelled, amnioinfusion can be used to dilute the amount of meconium in the amniotic fluid inside the utero. This will greatly decrease the risk of meconium aspiration. Some infants are also scheduled to be born by CS. This is especially true if there is deeply meconium stained during labor. During or after birth, suctioning is very important. At perineum, if there is meconium-stained amniotic fluid, suctioning must be immediately done to prevent aspiration. Intubate, if there is severe staining, to suction meconium in the lower respiratory tract. After suctioning, when there is already a patent airway, we can administer oxygen, then maintain on ventilation. Fourth, you may start antibiotic therapy. This is for prophylaxis against pneumonia. Surfactant may also be administered to improve lung compliance, especially if the child is preterm. Fifth is to maintain temperature-neutral environment to prevent increasing oxygen demand. Next, we can perform chest physiotherapy for removal of remnants of meconium from the lungs. And last, some are maintained on ECMO or extracorporeal membrane oxygenation. This is to ensure adequate oxygenation. SIDS, or sudden infant death syndrome, is a sudden unexplained death in infancy who die quietly in their sleep. Peak age occurs in 2 to 4 months. In autopsy, usual results reveal petechiae in the lungs and inflammation and congestion in the respiratory tract. The newborn appears well nourished. There is no sound upon death, so probably there is laryngospasm. And also, blood fleck sputum or vomitus in the mouth is often found. SIDS tends to occur at a higher than usual rate in infants listed in the slide. SIDS may be because of prolonged unexplained apnea, although its exact cause is really unknown. The following recommendations decrease the incidence of SIDS: positioning infant on back when sleeping, offering pacifiers when sleeping, putting fan in the infant's room to keep the air moving while sleeping, and using an apnea monitor. According to the American Academy of Pediatrics, compliance to these following recommendations cause a decline in the incidence of SIDS by approximately 50%. Hemolytic diseases of the newborn occurs when an abnormal RBC destruction in the newborn caused by mother's buildup of antibodies. Hemolytic means destruction of RBCs, but RBC destruction is a normal physiologic process. Let us again review that a newborn has fetal RBCs upon birth. This lives for about 90 days. In the adult, our RBCs break down every 120 days. During these days, normal RBC breakdown occurs, but if there is an abnormal destruction, that is when hemolysis occurs. This leads to severe anemia and hyperbilirubinemia. And these two diseases we will discuss further, RH incompatibility and ABO. RH incompatibility occurs when the mother's blood type is RHD negative and the fetal blood type is RH positive, which means the fetal blood contains the D antigen. The introduction of fetal blood causes sensitization to occur, and in this case, the woman begins to form antibodies against the D antigen. Remember that RH incompatibility only occurs when the mommy is RH negative and the baby is RH positive. When can sensitization occur? Theoretically, there is no direct connection between fetal and maternal circulation, so no fetal blood cells should enter the maternal circulation. But during pregnancy, an occasional placentae villi can break and drop. This fetal blood does enter the maternal circulation. Few antibodies form this way, however. The second case is the most common form when sensitization occurs in the first 72 hours after birth. This is when there is an active exchange of fetal and maternal blood as the placentae villi loosens. After several years, when the woman becomes pregnant again or for the second time, there is already a high level of antibody D circulating in the woman's blood. This was formed after the first pregnancy sensitization. This will now destroy the new fetal red blood cells if the new fetus is Rh positive again. In this case, subsequent pregnancies are most often affected. Assessment. Coombs test could be direct or indirect. Indirect is assessing for rising anti-Rh titer or rising level of antibodies in a woman during pregnancy, while direct is to detect antibodies on the actual fetal RBCs in cord or during birth. What are the findings expected? The newborn may or may not appear pale. This is because there is a possible acceleration of production of RBCs during the last few months in utero. This compensates to some degree for the destruction. There could also be progressive jaundice within 24 hours of life. This is called pathologic jaundice, compared to what we call the physiologic jaundice, which is expected or normal, where jaundice occurs after 24 hours of life. In this physiologic or pathologic jaundice, hemolytic process is at work for both RH and ABO. It is commonly seen among breastfed newborns due to the pregnanidiol. What is pregnanidiol? It is a breakdown product of progesterone, and this interferes with indirect to direct bilirubin conversion. It is excreted in the breast milk 24 to 48 hours after birth. Another is liver or spleen enlargement. This is an attempt to destroy damaged RBCs. There could also be extreme edema. As RBC decreases, blood may be hypotonic to interstitial. There's a fluid shift from lower to higher isotonic pressure by osmosis, and this leads to the edema. There could also be heart failure from severe anemia. This is when the heart has to beat fast in order to push diluted blood forward. In the picture, you will see that the child has developed hydrops fetalis. Hydrops fetalis is an old term for the appearance of a severely involved infant at birth. Hydrops means edema, and fetalis is the lethal state. The fetus can be severely compromised by the action of these antibodies crossing the placenta and destroying their red blood cells. So, as a management, intrauterine transfusion can be done to combat RBC destruction. Also, preterm labor can be induced in order to remove the fetus from the destructive maternal environment. Phenobarbital can also be administered to the women during the last weeks of pregnancy. These will reduce symptoms of hemolysis as it speeds liver maturity to convert indirect to direct bilirubin. But nurses could be cautious because administering phenobarb as a nervous system depressant causes risk of fetal sedation. Also, ROGAM, an immune globulin, can be given IM or IV. One dose between 26 to 28 weeks AOG to the mother and an additional dose within 72 hours after delivery. This will prevent production of fetal antibodies. In ABO incompatibility, hemolysis occurs mostly when the mother is blood type O and the fetus is either A, B, or AB. Usually, when the mother is O and the fetus is A, that's the most common form. The most serious one is when the mommy is O and the fetus is blood type B. As you can see in the table, the following red blood cell types, which contain the following antigens, would form the following antibodies. For example, the mother is blood type O and the fetus is blood type B. Definitely, the mother's blood type O contains the anti-A and the anti-B antibodies. These antibodies are present from birth in the newborns whose red cells lack these antigens. And because the fetal blood type is B, containing the anti-B antigen, there could be hemolytic problems. The blood and the antibodies were exchanged during mixing of maternal and fetal blood as the placenta is loosened. The same with the RH incompatibility. But reaction is less severe than RH and usually the firstborn is affected. The infant is not born anemic. As RBC destruction begins at birth, it may continue up to 2 weeks. Usually, jaundice and pallor occurs within 24 hours. Again, that is pathologic jaundice. Remember also that these antibodies are large IgM class. They do not cross the placenta. Breastfed babies also show more jaundice than bottle-fed ones. It's because of the pregnanediol as explained in the previous slide. Therapeutic management of hemolytic diseases. First is initiation of early feeding, just like or shown in the first picture. It is believed that bilirubin is removed into feces, so early feeding would stimulate bowel peristalsis. Second is through phototherapy. It's a continuous light in order to activate the liver in converting indirect to direct bilirubin. Third is exchange transfusion or DVET. This has been explained in our previous topic. It's an alternating period of hypovolemia and hypervolemia using the UV and the UA axis, where old blood is removed from the body and donor blood is transfused. It is usually a 1 to 3 hours procedure. Necrotizing enterocolitis or NEC is when an infant's bowel develops necrotic patches from ischemia of intestinal blood vessels due to hypoxia. The common causative agents are E. coli and Klebsiella pneumoniae. The growth of these pathogens interferes with digestion and leads to paralytic ill use. It develops in about 5% of all infants in the ICUs. Its average onset is about 4 days. It is highest in preterms, especially those with gastric tubes and on NPO, and also in neonates who are on mechanical ventilators. A child with neck would have the following assessment findings. In the photo, you will see it's very obvious that the abdomen is really distended and tense. Abdominal girth is very important to measure, especially when you are starting to care for a child who is on NPO with a gastric tube and on ventilator. Measuring it every day will help you assess the increasing risk or incidence of neck. There is also a lower incidence of this infection among breastfed neonates. It is because intestinal organisms grow more profusely with cow's milk or milk formula. It lacks antibodies. Therefore, the response to foreign protein in cow's milk can start the necrotic process. The mainstay treatment for newborns with neck is initially non-operative management. The first two items. Start with IV or total parenteral nutrition, and this will rest initially or temporarily the GI tract. The initial course would mean that you need to stop enteral feedings or put the baby on NPO and perform gastric decompression. It is also important to give a broad spectrum antibiotic for the infection. If the rest will fail, it is possible to perform surgery to remove the area of necrosis in the bowel. But be careful because neonates have an immature abdominal muscle. This will complicate further if there will be an abdominal surgery. Newborns from diabetic mothers. The following assessment findings are seen in this newborn. The main cause is because of hyperglycemia in utero. 1. High glucose level during intrauterine life is teratogenic to a rapidly growing fetus. Second, this high level of glucose in the uterus will stimulate high fetal insulin secretion. This causes overstimulation of growth hormone and extra fat deposits. And third, hyperglycemia in utero also interferes with cortisol. This blocks the formation of lecithin, so lack of surfactant also causes immaturity. The following complications can occur in newborns from drug-dependent mothers. The photo in box 26.13 shows the typical assessment findings when checking a newborn from a drug-addicted mother. These infants tend to be small for gestational age or SGA because the high level of substances in the maternal blood crosses the placenta and causes problems of intrauterine growth development. The high substance level also in the fetal blood will show withdrawal symptoms upon birth, but the onset and duration varies among different substances. It could be as short as 24 to 48 days or may last up until 10th day. Management. It is important to keep the newborn in an environment free from excessive stimuli. These substances affected the nervous system. So, excessive stimulation in the nervous system can cause further complications, one of which is seizure. Second is to maintain fluid and electrolyte balance. If the child is vomiting or has diarrhea, IV administration may be indicated. Focus on the child's nutrition, and it is important to make sure that you also weigh the child daily. Third is important because you need to start the drugs used to counteract withdrawal symptoms. Nervous system drugs such as paregoric, phenobarbital, methadone, chlorpromazine, and diazepam. Please review them. And fourth, avoid breastfeeding, especially if the mother is really a known drug dependent. This will prevent initially the passing of narcotics in the breast milk again. But you can give the child breast milk from other mothers. What is fetal alcohol exposure? It is when alcohol crosses placenta in the same concentration present in the maternal bloodstream. These can result to fetal alcohol syndrome. We said before that alcohol may be good for the body, but because it always crosses placenta, there is no safe level. The syndrome appears in about 2 per 1,000 newborns. It is more often difficult to document than recreational drug exposure. Again, there is a known safe of threshold. These may cause deteriorating impact on the placenta and teratogenic effects to the newborn, especially on the nervous system of the child. The following characteristics show fetal alcohol syndrome. There is prenatal and postnatal growth restriction. There is an obvious CNS involvement. It could be a cognitive challenge. There could be microcephaly or possibly cerebral palsy. We will discuss these further in the physiologic disorders. Children with fetal alcohol syndrome also has a distinct facial features. The photo shows the typical facial features of this child. Also, during the neonatal period, because of nerve system involvement, an infant could show the following manifestations, including being tremulous, fidgety, irritable. They have weak sucking reflexes and have difficulty with sleep. They may also have behavior problems such as hyperactivity in the school age. Fetal alcohol syndrome has no cure, so parents must be prepared for long-term care.